Today we're going to talk about routine venipuncture. So last week, or the very first lecture I should say, we covered chapter 8 in the phlebotomy book, which is about the venipuncture equipment, the different types of equipment that you need, and also about the different tubes, the tube colors, and what those mean for the different laboratory tests. Today we're going to go through the actual procedure of sticking a needle into a patient's vein. The first thing we want to talk about is requisitions. These are forms that come with the patient. Either they come down to the laboratory if the patient is inpatient, and specimen processing people who work in the processing area will go ahead and put this information in so that the right labels are generated for the phlebotomist, labels that actually go on the tubes, or they'll come in with the patient if it's an outpatient phlebotomy area. On the requisition, there will be the patient's first and last name, an identification number. If they're an inpatient or if they're linked through a hospital, they'll have a medical record number. A lot of times this number can be barcoded, which is nice because you can use barcode readers. It'll have the patient's date of birth. Sometimes it'll have whether the patient is male or female. It will have their location if they're in the hospital, meaning it will have the room number and maybe their floor number. I will have the ordering physician on it, the actual doctor who is ordering these tests, and the tests that are requested will be on this requisition. It also will have a sample collection date and time if a time is important or if the specimen needs to be collected on a certain date. A time example of an important time status would be, let's say an inpatient is getting a blood draw for a CBC every 6 hours. So a phlebotomist has to make sure that they're drawing the blood on time. They want to draw it 6 hours from the time it was previously drawn. So you don't want to be too early or too late on that kind of time status. It will have any special collection or patient information. For instance, if the patient should be fasting, that will be on the requisition. And then billing information, which usually doesn't concern either the phlebotomist or the laboratory workers. Greeting the patient. So when you enter the patient's room, you want to walk in with both a smile on your face and an air of confidence, even if you're not feeling very confident when you first start phlebotomy. It's important that you put the patient at ease. You want to walk in and you want to introduce yourself. Say, hello, my name is Katie Kavner, and I'm here to get a little bit of blood from you if that's okay. Just go slow, make sure you introduce yourself, and have an air of confidence. You want to explain the purpose of your visit, like I just said. I'm here to draw some blood, but use non-technical terms. Don't go into what types of tests they're going to have drawn. That is not for you to give them that information. That is up to their nursing or their physician staff. You want to obtain consent. It's usually implied when you're in a hospital. You can say, is that okay, or let's get started. If they vehemently refuse, if they don't want to give blood, you do not force them. You just smile and say, okay, I'm going to go talk to your nurse about that. And you go to the nurse's station and talk to the nurse and see what they suggest that you do. Sometimes you'll walk into a patient's room and they will not be conscious. If they're sleeping, gently wake them up. But they may, if they're in an ICU, they may be sedated, and then consent is implied. The physician did want these tests ordered. Always observe the patient's reaction. Are they nervous? If they're nervous, try to put them at ease and provide feedback to them. Say, could you please extend your arm, and let them know that's a good position or not. So you really want to have good communication skills. Before you enter the patient's room, you always want to look for any kind of room signs which would have allergies or restrictions. We didn't really talk about this too much, and I may bring this up in another lecture, but there are certain signs that go outside of a room. An allergy sign usually would be like a latex allergy, and in that case, you want to make sure that none of the supplies or materials you are using have latex in them, which most hospitals now do not have any kind of latex materials. The tourniquets aren't latex, the gloves aren't latex, so that's usually not a problem. Restrictions would be if the patient has certain restrictions, meaning they may have droplet isolation from having certain types of viruses like chickenpox. They may have contact isolation procedures from maybe MRSA. So you have to learn what those things mean and make sure you follow proper precautions, which would be on that sign outside of the door. Patient identification is the most important procedure in phlebotomy, and I cannot stress that enough. You have to make sure you identify your patient and you're correctly identifying your patient every single time you draw a patient. The CLSI, the Joint Commission, and the College of American Pathologists, the CAP, recommend two identifiers. In the hospital, that usually means their name and their medical record number. And in the hospital, they'll be wearing a wristband, and sometimes outpatients will also be wearing a wristband. So you want to have that wristband and your requisition, which in most cases would be your labels that are going to go on the tubes, and then, if possible, a verbal identification. So you're going to check what you have on your labels or on your requisition against what is on that patient's wristband. And then you want to ask them to state their name, and we'll talk about that in a future slide. The ramifications of misidentification could be quite severe. For instance, if a patient is misidentified and you're doing a blood bank procedure where that patient is going to receive a transfusion of blood, and you accidentally misidentify that patient and they get the wrong blood type, that could kill them, easily kill them. So that's a severe case of misidentification. So you want to make sure that you understand that the most important procedure in phlebotomy is patient identification. For inpatient identification, the patient should or must state their name. Never ask for the patient by name, meaning don't walk in and say, Mrs. Jones, with an open-ended, because if they are not lucid, they may say yes. They may not be with it. They may think they are Mrs. Jones. So you always ask them to state their name. You don't give them their name to them. Again, in cases where they are unconscious, they obviously cannot state their name, and you need to go by wristband identification. The wristband should have correct and complete information, and the wristbands must be present on the patient, meaning they shouldn't be on the bedside, on the drawers next to the patient. They should actually be on the patient's wrist, or rarely you'll find them on the patient's ankle. For outpatient identification, the patient should be able to state their full name. They're not going to come into outpatient hopefully unconscious. And then hopefully be able to give another identifier. Most often it's their date of birth. Rarely it's their address or maybe their social security number, although most places don't use social security numbers anymore. Some outpatient facilities are utilizing a wristband, so ask them to state their name, but then also check your requisition or labels against their wristband as well. So here's an example of a phlebotomist looking at the patient's wristband and checking it against the requisition or labels that she has. As I stated, there sometimes are barcodes on wristbands. Most of your inpatient hospitals and even outpatient are going to have a barcoded wristband with the medical record number that's interfaced with the laboratory information system. A lot of phlebotomists now actually carry barcode readers or radio frequency identification readers, have the ability to read the barcodes. As you're getting your materials ready, talk to the patient and give a brief explanation of the procedure. Most of them have already had venipuncture performed on them in the past, so you can usually just say, I'm here to perform venipuncture or to do a needle stick. Again, do not give any details of specific tests. Refer to the patient to their healthcare provider. Also, make sure you verify any pre-test instructions such as fasting. If you're doing fasting labs, they should make sure they haven't eaten anything for the last several hours, depending on what the fasting time is. And if there's any medications, for instance, if they've been on aspirin or Plavix or something that causes clotting to be slowed down, things like that. And then inquire about possible latex allergies, although again, that's not usually commonly done anymore because most hospitals and outpatient labs don't have any latex materials. Always position the patient for convenience and safety, both theirs and yours. Never draw blood from a standing patient in case they were to faint. Make sure they're not chewing gum, or if they're an inpatient, they don't have a thermometer in their mouth so they don't choke while you're drawing blood. If they're outpatient, most outpatient facilities have a drawing chair. Make sure their arm is fully supported and angled downward and is comfortable for both them and you. And if they are known to have a history of fainting, make sure they're in a reclining position. Inpatients are usually in a hospital bed, and you want to make the arm accessible to you so you're not basically trying to stand on your head trying to draw blood. And you want to support under the arm with it positioned downward. Usually using the bed in different reclining positions accomplishes this quite nicely. Bed rails should be lowered for access. You should also bring the bed up to waist level for you so you're not bending over and hurting your back. But however, whenever you raise bed rails or raise the bed, you must put them back to where they were when you started. In other words, if you put the bed rails down, make sure you raise them when you're finished. If you raise the bed up, make sure that you lower the bed back down when you're finished. Here's an example of a patient, an outpatient. They're sitting with their arm angled downwards. You can see that here. And here they're using a foam rest that they can put underneath their arm that helps them position their arm more comfortably for you to do the drawing. Now that your patient is positioned and you've already checked the ID of the patient, you're going to re-examine your requisition or your labels to see what labs are being drawn and select your appropriate supplies based on the patient's age and condition. And what that means is if you're drawing a child or an infant, you may be using smaller tubes than you would on an adult. You want to make sure that you have the correct type and number of evacuated tubes, meaning the right color, that you have the appropriate venipuncture needle and holder, and that they have a safety device on them, that you have your antiseptic, which is usually an alcohol swab, that you have your bandaging ready, and your tourniquet all ready to go before you start the venipuncture procedure. Before you've actually gone up on the floor, you've probably already inspected your supplies on your phlebotomy tray, meaning you've looked at the expiration dates, etc., and make sure that everything is as it should be. It's necessary that the equipment is selected and placed close to the patient. However, do not plop your blood collection tray on the bed. Number one, it's been all over the hospital, so it's probably not the cleanest thing in the world. And also, your patient could accidentally kick it off or hit it with their hand off the bed and make a huge mess. However, you do want to make sure that your equipment is accessible on the same side as your free hand. And we'll talk about that when you guys actually start drawing blood, how to make sure that you eliminate reaching across to get your tubes. For example, if you are using your left hand to put the tubes into the venipuncture holder, you want to make sure that your materials, your tubes are on your left side. You want to try and place tubes in the order of draw, which you guys all know by now, my mnemonic. Be romantic, girls like guys. Keep extra tubes handy in case you have a vacuum loss, because instead of losing the whole draw, you may just have to put a new tube on, and that way you save the draw and don't actually have to stick the patient again. Always then wash your hands and apply gloves. Perform this in front of your patient. You may want to wash your hands when you first walk into the room before you apply your gloves, and that's okay too. You just want to make sure that your patient knows that you've either washed or applied antiseptic to your hands. You do not want to use powdered or latex gloves. Grumpy Cat says no. And that's because you're trying to eliminate any allergies to latex gloves. And also, we don't use powdered gloves in the lab anymore because a lot of times they irritate the phlebotomists and the laboratory workers' hands. Next, we're going to talk about tourniquet application. We put a tourniquet on the upper arm, usually right above the bicep, to help impede venous flow. It allows accumulation of blood in the veins, making it easier to draw blood from the vein. It also makes it easier to locate veins underneath the surface of the skin. And while it impedes venous flow, it actually allows for arterial flow, which is good because you don't want to actually cut off flow of blood to the arm. You only want to leave the tourniquet on for about 1 minute or so. There's complications with prolonged application. You can get hemodilation, where blood starts to pool in the veins, which could theoretically affect certain testing parameters. And once you've released a tourniquet, it should be released for around 2 minutes before you actually reapply. Here's the proper way to tie a tourniquet. You can't really garner the information from a picture though, so we'll be spending quite a bit of time on learning how to tie tourniquets. Don't worry if you don't know how to tie one. When we apply it, it's not like we put it into a knot like you would tie a shoe. You want to apply it so that you can easily snap it off when you're done using it. For the site selection, you look for major veins, the antecubital fossa. That's usually the part in the crook of the elbow, the inside of the elbow. You have the median cubital, the cephalic, the median cephalic, and the base basilic. The veins tend to make an H or an M pattern, and I'll show you that on the next slide. Here you can see the site selection. If you look here, we have our basilic vein, which is on the inside of the arm. And here over here you have your cephalic vein, which is on the outer side of the arm, and it's up further away from where the crook of the elbow is. Usually what you want to go for is your median cubital vein or your median cephalic vein. The basilic vein tends to be a little more painful sometimes if you stick it, and the cephalic vein tends to be a little harder to get. I'm not saying you cannot stick these veins. You can. It's just usually if you can, you want to try and get the median cubital. You can see here that the veins make an M shape on this particular patient. Ways to locate veins is to have the patient clench their fists. Palpation by your hand can also locate the veins, and we'll learn how to practice that when we get ready to do phlebotomy. And then the use of landmarks. Sometimes patients will have moles or freckles or something that could help you find a landmark to help you find the vein. Unfortunately, I'm put this PowerPoint on my MacBook and it won't let me click on the embedded YouTube video to show you this device. So what I'm going to do is I'm also going to include the PowerPoint on e-learning, so you can go back and find this PowerPoint and go ahead and click on this. This is actually slide 21, so you can actually play this little YouTube video. It's only about 1.5 minutes long. And it shows you this new device that's coming out on the market. It's not in the United States yet, but it uses infrared light that's absorbed by deoxygenated hemoglobin in blood. So that can show you where the veins are located, since veins would have deoxygenated hemoglobin blood flowing through them. So when you get a chance, open up the PowerPoint that I post and go ahead and click on this and you should be able to watch it. Okay, now we're going to go on the assumption that you've put your tourniquet on, you've palpated and found your vein, and you've taken your tourniquet off so you can get the site ready for the venipuncture. So the first thing you're going to do is you're going to use an isopropanol alcohol swab to cleanse the area. And this is just to get any bacteria out of the way. If you were doing blood cultures, you do an actually much more in-depth antiseptic routine. But for routine blood draws, you just use an alcohol swab. You use a circular motion where you start in the center of where you're going to do the venipuncture and work your way outside in concentric circles. And this is to avoid contaminating the inside that you just cleaned with any bacteria from the outside. It's important that you let the alcohol dry completely before you start the venipuncture. And you want to avoid recontamination of the site, meaning once you've used alcohol to the site, you don't want to touch it with your fingers or even your glove finger, because then you have to do the cleansing process all over again. While the alcohol is drying, you want to go ahead and assemble your equipment. And this is just sort of multitasking. It makes sense to get your alcohol on the patient's arm and let that dry, and you can be doing other things while that's drying, rather than just sitting around and staring at your patient as you wait for the alcohol to dry. And that's putting the needle onto the holder, doing a visual examination, making sure you have everything ready, any extra tubes you may need, making sure your gauze is ready to stop the blood flow once you're done with the venipuncture, etc. Now you're ready to perform the actual venipuncture, and you're going to reapply the tourniquet. You don't want to palpate the vein again, though, because you've already cleansed the area. You want to go ahead and position your needle, and that is what we call bevel up. And you can see here, I have an example. Here's a bevel down. You want your bevel up. It's kind of a triangular shape that's hollowed out, and it'll make more sense when you actually get to see that. But this is the confirmation that you want your needle when you're getting ready to stick someone. You want to anchor the vein with your non-dominant hand. And what that means is that if you are right-handed, you're using your right hand to actually stick the needle into the patient's vein. You're going to use your left hand then to anchor the vein. You're going to take your left thumb and place it below the vein that you're going to go ahead and stick and pull the skin taut. And that helps keep from patients' veins rolling. And we'll talk more about rolling veins when we actually do venipunctures. But some patients have what we call rolly veins, or when you stick the needle in, the vein actually rolls away from the needle, and then you don't get the patient, you don't get any blood. And you want to insert the needle at a 15 to 30 degree angle. There's not much I want to say about this slide because you really have to learn how to do this by practice. You use your non-dominant hand to advance and change tubes. You want to minimize the movement of your hand that is holding the needle in place, meaning you want to keep that anchored and rock solid so that the needle does not slip out of the vein. You want to make sure that you mix the tubes that have anticoagulants in them by gentle inversion as you change your tubes to ensure that your tubes don't clot. Once you're ready to remove the needle, you want to do two things before you remove the needle. First thing is you want to make sure there's no more tubes. You want to pull any remaining tubes off before you pull the needle out, because that's a vacuum and it can suction on the vein as you're pulling out if you don't remove that last tube. The second thing you want to do is make sure that you remove the tourniquet before you remove the needle, because if you do not, you may have a lot of blood come out of the venipuncture site and you can cause a hematoma. You want to remove the needle in a smooth, swift motion, and then you want to put your gauze on the venipuncture site. After you remove your needle, you immediately want to activate your safety device. Do not wave that needle around. That's the first thing you want to do, even before you get the gauze on the patient. And then you want to apply pressure to the site. You want to immediately dispose of the needle and the holder in the sharps containers. Do not bend, cut, and definitely never recap a needle. Always use your safety device. When you're getting ready to bandage the patient, you want to check and make sure they're not bleeding excessively. You can use gauze with adhesive tape over it. You can use Band-Aids. You can use self-adhering bandages, what we call Coban. There's several different ways to bandage a patient, and it will depend on the hospital that you're training at and on how you will bandage your patient. You always want to label your tubes post-collection. In other words, never label your tubes before you actually draw the blood. That is basically begging for things to go wrong, because what happens is you'll label your tubes before you draw them, and then the tube won't have a vacuum, or you'll miss your patient and you'll have to toss those tubes, and you may not have extra labels. Most hospitals are going to have computer generated labels, so you won't have to worry mostly about handwriting a label. The information on the label should definitely be the patient's full name, their ID number, usually it's a medical record number, and then you may have to write on the date and time of collection and your initials or tech code for logging into the computer. So you always want to have a good pen with you. I prefer the really thin Sharpies. It's really important that you label your blood. I cannot tell you how many times blood and other specimens have come down to the lab unlabeled, and that causes a disservice to the patients because then they have to be restuck. There is a way that us people in the laboratory like our tubes to be labeled. You will see them labeled in all of these worst dressed ways. My special not favorite is the group hug, where they try and use one label for more than one tube. I've seen them use one label for 4 tubes. That is a huge no-no. Don't do that. The best way is to make sure the barcode is going straight up and down vertically, and that you leave a window open so that you can actually see the blood. And that helps the phlebotomist see how much blood they've drawn, and it helps the people in the laboratory when they spin the blood down or centrifuge it to see the plasma and to make sure that there's enough blood collected to run the tests. Make sure that you clean up all of your materials after you draw blood. Throw everything away in the regular waste paper basket, or if it belongs in biohazard, make sure it goes into the biohazard buckets or containers. After bandaging and after labeling the tubes, you want to recheck the identification. I always took my labeled tubes and compared them to the patient's armband. It's just one more check, and it doesn't take much time to do it, and that way you can say that you double checked your identification before you drew blood and after you drew blood. Make sure you return the bed to the original position it was in if you moved it, and always make sure the bed rails are up. Wash your hands or put on antiseptic, and then always thank the patient for their time. Once you've completed the procedure, you want to deliver your samples to the lab in a timely manner. Some of those labs are stat, so you want to make sure they get down there so the test can be run. Some are time sensitive, so you want to make sure that you're either sending them down by pneumatic tube system on the floors, or that you're actually taking them down to the lab as needed. Make sure that your appropriate paperwork is completed if you have paperwork, and or that your labels are properly attached to the tubes and have the information that's needed on them. And then also make sure if you're working on a computer system that you log the samples into the computer system. Now I'm going to walk you through the venipuncture procedure, and then we're going to watch a short film on venipuncture, and that should conclude the PowerPoint. Here in this slide we have the requisition that's come down, or they have the labels for the patient. Here is the patient, and you can see the phlebotomist is greeting the patient and introducing herself. This is an outpatient procedure. She's taking her labels and matching them against the patient's wristband, so she's identifying that the patient is correct. Here you see a no latex sign showing that they're not using any latex in the outpatient phlebotomy area. The phlebotomist gets all of her materials ready. And again, this is something you're going to practice. Don't feel like you have to come and know this the very first time you draw blood. Okay, we'll go over all the things you'll need again when you get ready to actually practice on the mechanical arm and when you get ready to stick your first patient. The phlebotomist is washing her hands in front of the patient, and then she's going ahead and getting ready to look for a vein. You can see here looking for the veins on the arm. You can actually see some of the blue veins right here. Here they tie the tourniquet. Again, I'll be teaching you how to do that. And she's palpating for a vein. See how the tourniquet is now untied as the phlebotomist gets everything ready. She takes her alcohol swab and gets ready to antiseptically clean the site. While the site is drying, the phlebotomist goes ahead and gets the needle onto the holder so everything is ready to go. She also gets the tube into the holder. Now, mind you, she's not actually pushing the tube up onto the needle yet. You don't want to push that up because you'll release the vacuum and you won't get a blood draw. But the phlebotomist is getting the tube into the holder so that it's ready to go when she's ready to actually stick the vein. Here, the phlebotomist is retying the tourniquet, taking the cap off of the needle, making sure that the needle is bevel up. Here you can see that she's holding the tube in her right hand. She does what I call a C motion. She makes her hand into a C, and I'm going to teach you how to do that. And she's using her left hand over here, her non-dominant hand, to pull the vein taut. You see the left vein when I talked about that earlier. She's pulling down the skin to basically anchor the vein so it doesn't roll when she sticks the needle in. Here she's going ahead and she's stuck the needle into the vein. Now when you go and stick the needle in, I'm going to let you on a little secret. The longer it takes you to put that needle in, or the more slowly you go, the more it hurts the patient. So you want to kind of commit. I don't want to say jab, but you kind of want to jab. You want to go in quickly. Now that she's got the needle in place in the vein, the phlebotomist is going ahead and putting the tube on. You can see the blood come back into the tube. And we'll talk about the proper way to do that when you actually get to practice. This hand right here is rock solid. She's holding it still while the blood is filling into the tube, and she holds it still while she changes tubes as well. You do not want to move this hand because moving this hand can cause movement to the needle in the vein, and it can cause the needle to come out of the vein, and then you will have lost your vein. Here it looks like the phlebotomist is done drawing. She's undone the tourniquet, although you can't see it very well. She's pulled her tube out, and she's getting ready to pull the needle out. Here she pulls the needle out. She moves the gauze over the site to stop any bleeding. And here she's capping her needle. So you can actually stop the bleeding and apply pressure simultaneously while capping your needle. Always cap your needle as soon as possible, and then dispose of the whole thing into the sharps container. Then next the phlebotomist is labeling her tubes, and then what I would do is check it against the wristband one more time and bandaging up her patient. So here is a short video that I'm going to go ahead and play for you right now, and you can watch it, and then you can go ahead and watch it on the PowerPoint anytime you want.
One of the most common procedures you'll learn. We begin with the needle, vacutainer, and blood tubes. A blood pressure cuff can serve as a tourniquet to help you raise a good large vein in the antecubital fossa. Tying the tourniquet properly takes a little practice. The universal precautions for this procedure begin with gloves and careful cleansing of the skin with alcohol or betadine. Carefully remove the cap to unsheath the needle. Insert it into the yellow vacutainer and screw it into place. Then lift the needle guard and remove the cap. You'll see that the hole in the beveled edge of the needle is facing up and is in line with the needle guard. Take a shallow approach to the vein and the blood flashing back into the vacutainer confirms you're in. If you don't see the flashback, stop. In this example, we're drawing a couple of tubes for the lab. Gently oscillate the tube to mix the blood with the heparin or stabilizing agent in the tube. To switch tubes without causing the patient discomfort, you want to steady your hand against the arm. Then you can pop in the next tube without pushing the needle any deeper. And as we finish, one pull of the tourniquet. Place the cotton ball above the puncture site, not directly on the needle. Withdraw the needle straight back and roll the cotton gently over the puncture, applying steady pressure. Having the patient bend at the elbow to hold the cotton in place can create unnecessary bruising. Flip the needle guard back into place, protect the puncture, and the sharp goes right into the container.
Okay, we don't have these types of containers anymore, and OSHA now requires us to throw the whole thing away, the needle and the hub the needle is put into. So you guys will be used to throwing the whole thing away. I just want to let you know that this was made before OSHA had those requirements. can see she's screwing the needle off. We don't do that anymore. We do not reuse those hubs. So that concludes the venipuncture, and we will be practicing this in class in the next couple weeks. I'll take you each individually and we'll work on learning how to draw blood for those of you that have not already drawn blood. The end.